What is peripheral arterial embolism for BPH or PAE? You've asked for a long time. I've read your notes, your comments, your emails, and said, look, can we talk about PAE? Is it a good thing for the prostate? Will it shrink my prostate? Well, today you're in luck because we talked with one of the experts on PAE. His name is Dr. Vikram Rajpurohit, who is a faculty member, clinical professor at NYU Langone Medical Center in the Department of Urology. He did his residency at Johns Hopkins Hospital and did a fellowship at the Icahn School of Medicine at Mount Sinai, vascular and interventional radiology. We went through the full spectrum of PAE with Dr. Raj. We spoke about who's the right candidate, how does it work, does it really shrink the prostate, and most importantly, will it help me with my urinary symptoms? Because at the end of the day, what we're trying to resolve is urinary problems related to the prostate. Will it help with that? Enjoy this great conversation, finally. Great conversation on PAE with an expert, Dr. Vikram Rajpurohit. Let's go. Before I proceed, I just want to clarify that this podcast and all Dr. Gio content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Now, please join me in welcoming our next sponsor. Hey friends, I have some exciting news for you. Between November 19th and November 25th, I am hosting the Prostate Cancer Summit. The Prostate Cancer Summit is a week-long discussion with the best of the best in the world of prostate cancer. We're talking about the best clinicians and thought leaders in natural medicine, the best thought leaders in radiology, the best thought leaders in focal therapy, in diagnosing prostate cancer, in diet therapy, in prostatectomy, in penile health after prostate cancer treatment. This has been extraordinary and fabulous and fun undertaking by me as a host of this summit that I think you're going to find so valuable. This is going to answer a lot of your questions, and you're going to hopefully find confidence and clarity around all things related to this disease that I believe is an opportunity for you to live your best life. So for more information on the Prostate Cancer Summit, please look at the link below on the description notes as it relates to the summit. Enjoy the summit, and I'll see you soon. Welcome to the Dr. Gio podcast. I am your host, Dr. Gio, where it is my pleasure and my focus to help you optimize your prostate health, optimize testosterone, erections, how to live better with age, and live your best life as you get older. My guest today is someone we've tried to have for a while here because you've asked, hey, what about PAE? Can you get somebody on PAE on your podcast? I hear about it. It might be a good option for me, but we have one of the experts, Dr. Vikram Rajpurohit. Vikram, I know I butchered that.
No, that was great. That was great. That was awesome. Thank you again for having me on.
It's my pleasure, and thanks for being on. Let's get right to it. All right, PAE. Let's start from a very basic level. What does it stand for?
PAE stands for Prostate Artery Embolization. Basically, it's the technique or the idea that we're going to embolize a vessel, and that vessel is a prostatic artery, or these blood vessels that actually go into the prostate and feed the prostate with blood, nutrients, and things like that. Embolization is a term where we use as interventional radiologists where we plug up that vessel. So essentially shutting down that blood flow to that area or the territory it supplies. We're essentially depriving the prostate gland of blood, nutrients, and over time, the prostate gland essentially shrinks, gets softer, and allows for that obstruction that you have when you can't pee or you're peeing too frequently, weak stream, those symptoms kind of gradually improve. And I think it's a great, intervention that we have this past 10 to 20 years to treat patients with, BPH symptoms.
I always tell my patients, Vikram, I said, look, I don't care how big your prostate is. I only care if it's squeezing the urethra, right? There's some exception to that rule, but not much. I mean, if it's a 300-gram prostate, now it starts pushing up against things and then becomes uncomfortable, even some erectile dysfunction. But for the most part, if it's a 100-gram prostate, is it squeezing the urethra? I've seen many small prostates squeeze the urethra. So my question is, when somebody does PAE, does it shrinks the whole prostate? Is there ever a time where it shrinks the prostate, but it doesn't open up the medium lobe where that covers the urethra? Like, what happens where we reach the outcome that we want to reach, opening up the urethra?
Right. No, that's a very good question. The prostate gland there's multiple components of the prostate gland. There's the transitional zone, there's the central gland, the peripheral zone, and BPH tends to happen, mostly right around the urethra. And there's anatomical differences where you can have what you mentioned or alluded to, the median lobe hypertrophy that could, push into the bladder, causing worsening symptoms and things like that. Now, when we, as interventionists, take a look at which patient to provide or suggest this procedure for, that question of your gland size comes up very often. And from my experience and what I've learned through my training and education is that a lot of the times the gland size doesn't really correlate well with your symptoms. I've seen patients who've had, the normal gland is around 20 to 30 cc's or 20, 30 milliliters in volume. I've seen patients who had the worst symptoms at 40 cc's, at 50 cc's. I've seen patients who've had 200-gram prostates and they're walking around fine. They have no problems. A lot of this is subjective, how you live your life, what you feel like you can tolerate. So that comparing objectively becomes a little bit more challenging. But, when we talk about what we intend to do with this procedure, we do notice that after we do this procedure, the gland kind of shrinks to about 2/3 of its size, or a 30% decrease. That's pretty typical for prostates PAE 3 months post the procedure. But does that also correlate with your symptom improvement? Not really. So symptom improvement that we've seen within 6 months to a year after PAE, patients, their IPSS score, that's what the surveys we give you when you measure what you're feeling like on the day-to-day basis. Those scores drop by about half to a little bit more than half by about 6 months to a year. Does that correlate with prostate size? Not really. So it's a good thing to think about, and that's a question we get asked very often when we see patients in clinic.
Great, thank you for that. So I think it's important for the audience to know, I don't think they know this. This is not done by a urologist. This is done by an intervention radiologist. Can you expand on that? And if there's any even historical context that that would be great too. I'm actually curious.
Yeah, absolutely. So I'll start by saying this is like my elevator pitch when I'm talking to my friends, my family, whoever. It's like, what is an interventional radiologist? What do you do? What does that mean? Right? I start by saying, nobody gets it. In the hospital, like 10 to 15 years ago, we were in a department called special procedures.
Right.
It's like we were the ninjas of the hospital. Nobody would ever see us. They would just send us patients. We would get stuff done, and the patients would come back, feeling very good and having good outcomes. Interventional radiology is a subset of radiology or diagnostic radiology that started about 50 to 60 years ago, 1950s, when the radiologist was asked to take an image of an artery in the leg or even in the heart. That came up 20, 30 years later. And then slowly, instead of just taking images, they started doing interventions or intervening. If there was a narrowing in the leg artery, in your femoral artery, they essentially would dilate that narrowing up. What we call now angioplasty, where we, instead of like a dilator, you put a balloon, you blow up that balloon and open that artery up. And as many of our patients know, in the older distinguished gentleman population, a lot of patients have heart issues. A lot of patients will have a heart attack. We'll see a cardiologist. An interventional cardiologist, they essentially would, access the artery in your wrist or the artery in your upper thigh, navigate throughout your body, get to the heart, see where that blockage is in your heart, and would perform angioplasty or potentially put a stent in. That's what an interventional cardiologist would do. An interventional radiologist or a body radiologist would do kind of the same thing for rest of the body, not including the head. You have neurointerventional expertise with that. You have interventional cardiologists with the heart. We do everything else south of the neck except the heart. And prostate artery is like something that we've kind of discovered really helps patients with BPH as recently as in the early 2000s. There was a study published in 2000 where while this procedure was being done for patients with hematuria or basically bleeding from the prostate, whether it's from cancer or BPH, this procedure was done when those patients couldn't get surgery. Nothing was really resolving their bleeding. We would block the prostate artery just in the same way we would do now. But we started to notice that patients who had BPH symptoms as well started to get improvement in that aspect. So that's what started the cascade of looking at this procedure, studying the data, studying the population, and saying like, hey, this is actually making a big improvement for patients who just have BPH, not necessarily patients who are bleeding. And that's where this.
So it's like an incidental finding. It's like the Viagra. Yeah, kind of. It's like the Viagra story a little bit.
Exactly. And you have like all these hypertension medication that people are looking for hypertension. Well, oh my God, this makes my erectile dysfunction so much better.
Right.
And let's just keep going with that.
Yeah. Right. Interesting. Where do you insert the portal or whatever it is that you call it to lead down to the prostate and block the arteries there?
Yeah, absolutely. So when we start the procedure, you'll come into our like outpatient center. The nurses will put an IV into your arm, for sedation and things like that. This is not done under general anesthesia. Basically,
it is not done through general anesthesia?
No.
It's local anesthesia.
This is local lidocaine, and oftentimes we give a mild sedative that you would typically get when you have your colonoscopy or endoscopy or things like that, where it's a twilight sedation. Two medications called Versed and fentanyl. Patients typically fall asleep. Some of my patients actually want to watch, and I've like, go for it. Yeah, absolutely. There's a big screening that we're watching, they're watching, so it's like it's a nice kind of experience. Oftentimes patients fall asleep. It takes about 2 hours. So the portal that what we kind of access is the radial artery, the artery in your wrist where you feel your pulse. There's also a big artery in your upper thigh called the femoral artery. And that's what you can probably feel if you palpate your groin area as well. We put a small needle into that artery, no big cuts, nothing like that, just a small nick the size of your fingernail, maybe probably even half the size of your fingernail. Thread that needle with a wire, and then do the same thing where we get that wire and a catheter, which is a small tube, navigate it using x-rays, getting it to the prostate gland. And that's pretty much it. After 2 hours, you walk out with a small bandage on your wrist or your small bandage on your groin, and you're back to your daily life.
Why would you choose radial artery versus femoral artery or vice versa?
That's a great question too. So we, as interventional radiologists, most of our expertise has been done with femoral artery, and radial artery experience has been 20, 30 years in the making. And a lot of cardiologists, a lot of IRs now use radial artery because one, it's a little bit more comfortable with the patient. They can get up right after the procedure. They can walk. They can go to the bathroom. They'll just have like a wristband, kind of like a watch over that area, just to hold pressure. For us, in terms of navigation, sometimes there might be a little bit of atherosclerosis, which is plaque that gets built up in the arteries that may make it a little bit better for us to navigate from the top or navigate from the bottom. How do we decide that? Sometimes, we'll either get a CT of the chest, abdomen, pelvis just to get a lay of the land. Oftentimes, there's already something done for our patients for some other medical reason, and we just take a look at that. You can imagine, getting from point A to point B, it's probably easier just the shortest path possible, and that's what we get all the time. The upper thigh is so much closer to my prostate. Why don't you just use that? Isn't it harder going from the wrist? Sometimes the distance doesn't matter, but just the tortuosity. So a straight line is much more easier to cross than is a squiggly line. In the pelvis, your vessels may make all these turns, corkscrews, and things like that may make it challenging for us to navigate. From the wrist, we kind of go up, down, and then we're there.
So despite the proximity from the leg, the upper thigh to the prostate, it may be that these blood vessels kind of makes all kinds of turns where right from the radial artery, you could go up and go around, go down, and you're right in there.
Yeah, you kind of avoid those turns. The angles are more favorable. It just makes the procedure a lot faster. lot of our patients, honestly, many patients don't mind the femoral artery because that's what we do for most of our other procedures for other reasons. They are able to walk around after about half an hour to an hour staying on the bed. Radial, it's just a little bit nicer. You are able to just walk around right after. That's the only difference.
What do you prefer as a practitioner? So I know in the world of prostate cancer, sometimes, and I'm not a surgeon, but I've worked with urologists for so long, sometimes they prefer, even for biopsies, like transperineal, not only for infections, but they can target areas better. It's just easier and better to target. Some procedures for a prostatectomy or one angle is better than the other or whatever. And so it's like, yeah, I prefer this. And if I can, I'll do this. But what is your preference as a practitioner, radial or femoral?
I like radial.
Yeah,
I'll be honest.
yeah.
I like radial, especially in the younger patients who have no real disease in terms of atherosclerosis or calcified plaque. Radial is much faster. It's much easier. You're done maybe in an hour, sometimes maybe an hour and a half. For the more elderly population who do have a lot of atherosclerosis, sometimes the tortuosity, even in the chest and abdomen, make it challenging. And for those, I'll take a good look at their CT scan and be like, maybe I can just go access the femoral artery either on one side or potentially even on both sides and just hook these vessels like I need to and then be done that way. There's certainly certain cases for each one, but if I had my choice and the patient was ideal for it, radial is the way to go.
So the procedure is about an hour, let's say, hour and a half maybe. Do they leave with a catheter? And if so, for how long?
That's a good question. These are all the great questions that I get often asked in clinic as well. For the patients who've never had a catheter before, who've never gone into what we call urinary retention, we say that most of the times, 90% of the times, you're going to go home without a catheter. We just make sure you're able to urinate before you go home. Give you the instruction that, hey, there's a 10% chance the prostate actually swells up or gets inflamed from us blocking off blood flow. When that happens, you might have some difficulty urinating the first night. If that happens, give us a call, and then we can direct you to where to go if you need to get a catheter in. Knock on wood, in my experience, I've treated over 100 patients in the past 2-3 years. None of them had to have emergent catheterization for that. It does happen. That is something we want you to know about. Now, for the other subset of patients who have had catheters in the past but not currently, we might tell them, hey, are you able to self-catheterize? Do you have catheters at home that you can do in case this does happen? Or we can just put one in just on the safe side and you can take it out in 1 to 2 days. Now, my favorite population is the patients who are suddenly in acute urinary retention, who've had catheters placed in maybe a week or 2 weeks before because all of a sudden they can't pee anymore, they can't urinate, and they're like, oh my God, now I'm stuck with this thing. This is a huge detriment to my life. It's really impacting the quality of my life. Those are my favorite patients, to be honest, because this procedure can get them catheter free in about 2 to 3 weeks. All right, and that's a huge change to their lifestyle, and the success rate of that, if the catheter has only been in for about a month to maybe about 2 months, is way higher than 90%. So these are the patients that come into me after about a month. They're like, Doc, I am so happy for you. They're the ones hugging me. They're like, not only is the catheter out, but I'm like peeing, maybe not like I was a 20-year-old, but like maybe a 35, 40-year-old, and they're happy.
You mentioned that if they had a catheter for about a month, they're going to have good success rates after. Yeah. What's that time span that we know people who've had catheters for years sometimes? Is there limits? Like if they had a catheter for over a year, maybe PAE is not the right treatment for them? How would you go about that?
Yeah, I mean, the year is typically my cutoff. I'm going to, explain that what happens over time when you have a catheter in is that your bladder stops to push. Right? There's nothing holding the urine back. So your bladder doesn't really need to push when it distends. The urine just flows out into the back. So what happens is now the bladder is just not getting that stimulus. It's getting weaker over time. So what we've seen is that if we do these embolizations for patients who have had a catheter in for about a year, that success rate goes down to about 50% or even a little bit lower. So these patients, I mean, sometimes, going into surgery may be a little bit too daunting or it's maybe there's other risk features that they don't want to undergo, or there's other things that make surgery too high of a risk to even do. Can we do PAE? Is that worth the risk of, 50% that we may not be able to get the catheter out? Maybe. I mean, that's a personal discussion. And I think that sometimes we can get it out and it's a huge thing, but other times, it unfortunately doesn't. And I don't want to say no harm, nor foul, because it's a procedure that you go through, but the risks are fairly low.
Ejaculation, so that's one of the concerns that they have with all their options. Can I see, Vikram, I never had any prostate problems, thank God. Hopefully I don't have one, but you never know. All you need to do is have a prostate and live long enough, and eventually you probably will have some prostate problem, despite my lifestyle practices. But anyway, and I hear patients, right, and say, well, I want to make sure that I can ejaculate. And as a person who has a normal sexual life, I'm thinking, as long as you reach an orgasm, why does it matter?
Right.
It matters to a lot of these guys. Yeah. I still don't understand why, but it matters. So it's like, I'd rather preserve my ejaculate and ejaculate. Well, now for many decades, I've had many men ask me, look, is there a device that I can use to massage my prostate? Because my urologist is not doing it. Quite frankly, no one is really doing it. And for hundreds of years, prostate massage has been really important, actually, for just prostate health and people suffering from prostatitis. Well, now I just discovered our next sponsor, who are amazing in their innovation. This is the Malto device, which is a device that is clinically proven to support prostate wellness, designed with an ultra slim flexible structure that mimics the index finger for comfortable targeted stimulation. This device is developed by top urologists, and offers unique benefits to enhancing prostate health with potential improvement in erections and even ejaculation. How's that? Its flexibility allows to adapt naturally to the rectum, reaching the prostate with precision, and it includes 16 customizable intensity levels that can be controlled via a free app, giving user full control over their vibrations patterns for personalized experience. This is an FDA-registered device and stands out from competitors for its thoughtful design and ease of use, making it practical solution for optimal prostate care. The Malto device, guys, we finally got one. I have not been able to endorse any or have any that I've been happy with. The Malto device is the way to go. Please check down in the description notes for more information and a link to the Malto device for prostate health. How does PAE work in this manner? Can they still ejaculate?
Yeah. So the big thing, there's a couple of the things with ejaculatory function and erectile function that we kind of have to separate and tease and talk about. There is, for ejaculatory function, there's something called retrograde ejaculation that happens with a lot of the surgical procedures. That does not happen with PAE. So there's no way that the ejaculatory or the semen can actually go backwards into the bladder. Mm-hmm. That occasionally can happen in other kind of urological procedures. Mm-hmm. There have been studies that looked at a decrease in ejaculatory volume and things like that. And we've seen that that happens in about 10% of patients who get PAE. Most of my patients, they say there's no difference. Some of them actually say, now we're talking about erectile function, there's actually some data that shows that some patients have improved erectile function after PAE. And that needs to be a little bit more studied.
What would be the hypothesis there, even if you don't know exactly why that would be?
Yeah, it's hard to tease out. It's certainly maybe related to improvement in blood flow. When we're depriving the blood flow to the prostate, we're improving the blood flow to the penile gland. Something like that's where the vascular
redirection of the blood flow that's not going into prostate, going somewhere else.
Yeah, that's my hypothesis. It certainly could be way off base. Yeah. But I mean, we've seen reports when, even though these studies haven't been geared to look at that, have shown that, some patients, about 20 to 30%, have shown an improvement in their erectile function, which is an interesting thing.
PAE for erectile dysfunction there, Vikram. I mean, this is another Viagra story. This is the next Viagra story right here.
It just keeps getting better and better. Absolutely. We'll see.
So the other concern, of course, that the listener has or would have is, all right, get the PAE. How long does it last? How long would I keep my urinary function going well before I need yet another procedure, whether it's PAE or something else? So TERPs could be 5-7 years, for example, and everything is compared to TERPs, right? Nothing is compared to any of the newer kids in the block. So go ahead and take this in whatever direction you want with regards to how does it compare to TERP? When do you need to revisit this because the symptoms return?
Yeah, like you said, like most of the randomized clinical trials that we have with PAE is specifically comparing with TERP. There's some systematic and meta-analysis that are looked comparing it to other things, but the best data is against TERP. There's a recent study that came out in terms of a 10-year follow-up amongst patients, and they've kind of showed that about 20% of patients in 5 years may require something done again. That could be either another PAE or it could be another procedure. Mm-hmm. Basically, the symptoms kind of occur again over the span of 5 years, and 1 in 5 patients may have something else they need to be done. That kind of goes up to maybe 20 to 30% in about 7 to 8 years. So the durability is still kind of being sussed out, assessed, and kind of seeing what the longevity of this is. But one thing to note about PAE is that whether you have it done does not preclude you from having any other procedure down the road. All the doors are still left open.
So in 5 to 10 years, let's say, by the way, let me plug something in with my work. What I try to do in cases like this is, with my approach, the natural approach includes nutraceutical supplements, includes lifestyle, includes, what's the, gun in my head, what's the number one thing that can, induce BPH and urinary problems? Well, many things. I look at many things, but what's the one thing, gun in my head? Metabolic syndrome, right? So metabolic dysfunction has been associated with most urological problems, including BPH. These are things with like men with hypertension and high LDL, bad cholesterol, in air quotes, high BMI, several things. Glucose. They fix that improves their BPH. There's also a connection between, for example, constipation and bowel health and bladder health and, LUTS, lower urinary tract symptoms. So in my humble opinion and experience, when people do any of these procedures and then they take kind of matters into their own hands, they're proactive, you reduce the risk of needing to revisit this or having, or the symptoms are relieved for a longer period of time. So I just want the audience and maybe even you to understand that if they do some of these things after PAE, hopefully they don't need to, they won't have a problem for a while.
I completely agree with you. Couldn't have said it better myself. I think lifestyle modifications and getting your overall health and wellness in order definitely makes an improvement. It's almost synergistic in that world, right?
100%.
So when we're doing something in the base physiologic level, but then once you get your entire body into a rhythm, into some area of health, it definitely expands and improves your quality of life.
Yep. But let's just say either the listener is not doing the lifestyle modifications, or I don't know, it didn't work. Let's just say nutraceutical supplements or whatever, it didn't work. Do they do a PAE again? Or do they now have to do something else with a urologist, another medical procedure?
Yeah, I think that's a little bit more of a personalized case-by-case discussion, depending on what the surrounding is in terms of what the prostate gland looks like, what materials we use for initial embolization, if there's a big vascular pedicle that's still there. Mm-hmm. The theory behind why you get recurrent symptoms after even those 5 years is that the body is remarkable in that when there's a blockage in the road, it'll start to make new roads to get to where it needs to go. So the body will form new vessels, new mm-hmm. arteries to feed that prostate gland, and over time the prostate gland will grow. But the difference is, instead of having that 1 or 2 main roads that you originally had when you were born, now you may have all of these side roads that aren't really well formed, but they're still feeding the gland because of their number. And that may make prostate artery embolism a little bit more difficult. So, in those cases, we may say, okay, this may not be the best option. We may not be able to give on a great treatment. Maybe see a consultation with a urologist, see if they can offer anything else. Yeah, that would be my recommendation.
If there's some treatments for, let's say, even prostate cancer, there's radiation intervention radiologists that are involved in that and treating prostate cancer.
Right.
However, if there's a complication, they have to see a urologist. And sometimes they're not in synergy because the urologist is like, yeah, I don't know this procedure by the intervention radiologist, so I don't even know what to do here other than just regular, something that I would do to anyone who has some obstruction or anything going on. How's the relationship between the interventional radiologist who does PAE and the urologist, so that then if there's any complications, that the urologist can actually take care of the situation?
Right. That's a great question. I think, our relationship with urology, at least at NYU, is, I can't be happier. As soon as I started here, I got in touch with Dr. Chris Kelly, and we had a great discussion about how do we want to build this practice. And I know that Dr. Kelly was on your podcast earlier, and I think this relationship has just grown, and we just continue to talk about patients, send each other patients when I have something that I can't do. You just be honest. We're not about building practice just by doing procedures and doing procedures over time, but making sure the patients are getting the best they can get. And honestly, we've formed a relationship where Dr. Kelly will ask me, hey, I don't want to take this person to surgery because I'm worried about bleeding X, Y, and Z. Can we do prostate artery embolization beforehand? Let's get the prostate smaller. Let's devascularize it. So when they wanted to remove, when they want to go to surgery, it'll be a much better operation. So those kinds of collaborative ideas only form when you have. So I would certainly look for that when you go out and talk to your doctor about this kind of procedure. And if you find an interventional radiologist, that talk to them about what the relationship is like with the neighboring urology group, because it's definitely invaluable. Certainly when we have our patients who need a catheter or need a little bit more extra TLC, that relationship where we can call up Dr. Kelly, call up anyone in that office,
Right.
Like, can you help me with this problem? And that relationship is again, very invaluable.
Yeah, part of a multidisciplinary practice. So how many intervention radiologists are doing PAE? I know someone maybe in LA, but it's not like I have a wide list of people that do PAE. Yeah. So if somebody in somewhere in the US saying, oh man, is there somebody near me? Where do they go to find out?
Oh, that's a good question. I would say, first of all, start on Google, start on YouTube. There's a bunch of interventional radiologists who do PAE or have a social media presence and talk about the procedure. And I would recommend going to your nearby university website and see what their interventional radiologists do there. PAE is a fast growing, subspecialty within IR, and there are many attendings and physicians that are just building their career off of this and learning about more the nuanced things in PAE. So at this point, I think if you type in, there's one website I always tell my patients to go to. It's called ask, the number 4, PAE.com or .org. I'm sorry, I forget which one exactly it is, but it's askforpae.org or .com. And that kind of goes through all the FAQ behind what most patients kind of want to know about for PAE. And from there, just do a Canvas search in your area for those interventional radiologists to do, because this is becoming a much more popular and intervention. And especially as what I do want to plug is that the AUA, which is the American Urology Association, recently in September 2023 has now promoted PAE as a therapy that's no longer just experimental. With all of the data that's been coming out and all the studies that have been done on it, this is now, even in the urologic guidelines, PAE has become a procedure that can be done that is actually recommended in certain situations. So with that, I think the availability, the awareness of PAE is just going to keep going up and up.
Vikram, here's the $1 million question. I'm a patient.
Yeah.
I'm 55 years old and I clearly need a procedure. And I go online and there's literally like 15 options I have. I go visit each doctor and they'll say, no, this is what you need to do. Whatever it is that they are offering is what you need to do. You go to the whole lip guy. Oh man, this is what you need to do. You go to the guy that does Urolift. You go to the, green light laser, aquablation. And it's like, how do I choose? How do I make a decision on, somebody's listening to you this episode right now is like, oh, that's it. PAE is the way to go.
Right.
It's like, how can a patient make, right? Because we are in a time where I think most institutions, medical institutions, they are appreciating a shared decision making with patients. It's no longer the time that you have to do this and that's it, or the doctor kind of commands the whole thing.
Yeah.
And then patients do have access to information. They have access to poor information through the internet, but they also have access to pretty decent information as well. So how can they choose or be involved in that decision making?
Absolutely. Great question. I think, with this past couple of decades, there's a ton of procedures coming out for prostate, for BPH. The one thing that we have is PAE. The urologists have everything else, an alphabet soup of kind of different treatments. What we can kind of guide patients in is that, what is the best thing for them? What does their prostate look like? How difficult is it for us to completely do our procedure with the technical success that we want to do? That's something that I can guide in terms of the PAE, and I'll defer to the urologist to guide, what different procedure that they want to recommend for each patient. Now, if I have someone who says my symptoms are getting worse, the medications that I'm taking are not working, or I have side effects of these medications like dizziness, lightheadedness, or decreased libido, things like that, they don't want to take these medications anymore. But they don't want to go to a more invasive procedure. They don't want to go to a procedure that may have complications that they don't like retrograde ejaculation, like ejaculatory dysfunction. They're worried about having catheter for a long period of time. They're worried about having general anesthesia. They're worried about having all of those things. PAE, I think, in my personal opinion, is one of the least minimally invasive procedures with a very good complication risk profile. We occasionally, the risk that I typically tell, or the recovery that I talk about, is that you may have a low-grade fever for a couple of days. You may have some burning urination discomfort while on urination for maybe a day or 2 days. We give you a couple of medications to get through that, but your recovery phase is probably about 24 to 48 hours, maybe 72 hours, and then you're back to your normal life. So the risks of your erectile issues or ejaculatory issues is almost zero. In terms of retrograde ejaculation, your risk of being in the hospital for over a week is zero for these things. There's always these risks of mild infection and maybe some blood in the urine.
Comes naturally with any procedure.
Right. Yeah. Those things and they'll be self-limiting. There's nothing that you'll have to do with them. They'll recover on their own, resolve on their own. So while I may sound like I'm really in 100% go for PAE, there are some patients that I don't feel it would be the best. Those patients that, had a catheter for over a year, over 2 years, things like that. Sometimes when the gland is too small, it might make it much more challenging, almost impossible for us to get into those small arteries that are feeding a very small gland. So if you have really bad symptoms, like on an IPSS of 20 or higher, and it's like really impacting your life, but your gland is only 40 to 50, I would suggest, really think about your decision in terms of how effective can we be, either technically or clinically, by doing a PAE in those smaller glands versus maybe urologists if they're doing PUL, which is UroLift, or other minimally invasive procedures that they can do in the office. Those are where, it's a little bit harder to guide, because then it becomes the patient's choice. And ultimately, it is always the patient's choice. And when they hear that, hey, I can get this procedure done in the office, mild sedation, go home same day, it becomes a very easy choice for many people.
Is there a prostate that's just too big to do PAE? So if you have a 300-gram prostate and is reduced by 30%, that's not that significant reduction, right? It's still 200. I don't know, what is it? 270 grams or 260 grams still.
Right.
So you're still up there. Is it still effective? Is there a limit? Yeah, after a certain size, they'll have to do something else.
Like what we remember when we talked about before, the size, how it correlates to your symptoms, and what else we're doing with the gland. So I think even if we get the 30% reduction, what else happens to the prostate gland besides getting smaller? It gets softer. So there's two components. There's a static and the dynamic component of this obstruction, and the PAE actually targets both of them. So there is a potential that they may not need anything else after, even with a 30% reduction of a 300-gram prostate. Do we have the data specifically for those patients who have 300-gram prostates, and we looked at that? No. So could it, there's a little variance there. But if their symptoms are still significant after the prostate artery embolization, maybe surgery at that point may become a little bit more manageable. Maybe the risk of surgery, the blood loss, or the recovery is a little bit easier. Even the surgery itself may be a little bit easier. So in those situations, PAE still would be recommended. There's no...
Go ahead, I'm sorry.
There's no upper limit of size where we say we cannot do this. Mm-hmm. Would the efficacy kind of diminish a little bit? Potentially, but there's no hard stop there.
This softness of the prostate that you keep mentioning, what does that mean? And how long does it stay soft? So once the procedure is over, does it go back to being harder, or what happens from a texture perspective, if you will? I don't know.
Yeah, absolutely. So actually, one of the medications that we take, finasteride, or things like that, 5-alpha reductase inhibitors, that actually contributes to the softness of the gland as well. So basically, when you're doing this prostate artery embolization, all the ischemia or the lack of blood flow, all the cellular damage that happens also makes the tissue softer. And that is persistent, until the vascularity of the prostate kind of reforms and there's recurrence of these BPH nodules. So when there's new nodules that form back, then those nodules won't be as soft any longer. And that's why you probably have that recurrence rate in about 5 years.
Wow, this was great. This is, I wouldn't say it's a master class, but close to a master class on PAE for BPH. Vikram, thanks so much for being on. Final words.
Absolutely.
And if somebody wants to get in touch with you, how would they do so?
Yeah, great. Absolutely. Again, thank you again so much for having me on. It's a pleasure. I would say, for a lot of patients who don't even have a urologist or are having these symptoms that are starting to occur, and they start to take note of it. Hey, I'm going to the bathroom. I'm waking up many times at night. I'm going to the bathroom too often. I have to plan my days around where the next restroom is. Start talking to your PCP, start talking to your primary care physician. Maybe if you have a urologist, bring up, what is this procedure PAE called? I've just been hearing about it. Can you tell me more? Definitely going through your PCP or urologist is beneficial, but there are definitely physicians out there that will see you, just out from the public, and will happy to talk to you and discuss the procedure and what it means to have this BPH diagnosis and how to manage it. And I am very passionate about it because I've seen the significant improvement.
The other thing is that you should be, as a natural doctor, and I help sometimes patients navigate what medical procedure they need, although I don't do any of them because they trust me and they're saying, look, you don't have an axe to grind, so where do I go? I tell them, and patients oftentimes think, look, yeah, of course, the PAE guy wants to do PAE, and the other guy. And I said, look, there's a level of passion there that I actually appreciate. You want them to feel passionate and to love what they do and to be even biased with what they do. You're human. I'm human. I'm inherently biased. We all are. Right. And the fact that you done this procedure over and over again, and you tweaked it and try to just perfect it, probably keeps you up at night sometimes. I want you to be that person. And particularly if I'm going to do this procedure with you, or you're going to do this procedure on me. So I appreciate that.
Right. No, yeah, absolutely. I mean, there's nothing better than seeing the patient or my patient a month after. I'm like, you've completely changed my life. Thank you so much. I wish more people knew about this. Yeah. That is the one comment that it usually happens like, oh, one of my friends, my brother told me about this, but nobody else told me about this. I don't know why it's not out there more than it is. So I urge everyone who's having these issues just to talk to your PCP about it, talk to your urologist about it, because it's become.
I don't know that their PCP will know much about PAE, Vikram. I don't know. I tell you right now, this podcast right here, when it's up, this is going to be a resource for people because they won't know. They won't even know to ask the question. Because, and many urologists, so actually that's a question. How do people find you? The urologist may not say PAE. The PCP may not even know about PAE. So how would people want to, undergo this procedure if they, if no one is mentioning it?
It's a good question. I think what's going to help us a lot is the AUA recommendation that PAE is a thing, right? So that's going to spread the word, especially in that community. Just talk to your doctor. Be like, can I talk to an interventional radiologist? Can I talk to a radiologist who does an embolization for the prostate?
Yeah.
And they're going to find you that path to get to us. For me specifically, I'm at NYU Langone. So if anybody wants to reach out, my name is, again, Vikram.Rajpurohit, and that's my email, vikram.rajpurohit@nyulangone.org. I'm happy to answer any questions and direct to anybody that would be closer to you in terms of if you want to talk to you about PAE or any other procedure in general.
And I'll have you, with your permission, I can have your name, because you just said your name, but they're not going to spell it correctly, guaranteed. But I can have a link to your profile, and they can find you through there.
Perfect. Yep.
Vikram, great. Thanks so much, brother. Such a pleasure. This is the first time, though we're in the same institution, this is the first time we actually get to meet each other, nonetheless speak. Exactly. So I appreciate you, and I appreciate the work that you do. And thanks for being on.
Thank you so much. I was so happy to be here, and it was a pleasure. It's all mine. Thank you.
Thank you. All right, everyone. Thank you so much for listening. Hopefully this was helpful. Anyone who is thinking of a medical procedure for BPH, this is one of the options. And hopefully all the questions that you've asked me that I had no answers for, you got them answered. So hopefully this is helpful. Have an amazing day, and I'll see you next time. Dr. Gio here, signing off. Talk to you soon. Thanks for tuning in to this week's episode of the Dr. Gio podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgio.com. I'll see you next time.